So I'm thrilled to be able to introduce Anya Plutynski to the MCPHS community. Dr. Plutynski is an associate professor of philosophy at Washington University at St. Louis, affectionately known as WashU. She received her undergraduate degree from University of Chicago, her master's degree in biology from UPenn, and her PhD in philosophy also from UPenn. Her research specializes in philosophy of medicine, philosophy of science, research ethics, precision oncology, cancer genomics, and risk communication. Her current research is on the history of cancer, Genome Atlas Project, the development of precision oncology. I counted her CV, I counted about 50 publications, including articles, book chapters, reviews, and encyclopedia entries. She also edited 2 definitive anthologies, including Blackwell's Companion to Philosophy of Biology and Rutledge's Companion to Philosophy of Biodiversity. Her 2018 book, Explaining Cancer, Finding Order in Disorder, was published by Oxford University Press. She has served on the National Science Foundation Science, Technology, and Society Review Panel and the Philosophy of Science Association Women's Caucus. She's the associate editor for the British Journal for Philosophy of Science, one of my all-time favorite journals. It's a great journal, and biology and philosophy and so on. It is a remarkable list of accomplishments, to say the least. But most importantly, Anya is an amazing philosopher. Her rigorous scholarship shows how philosophy and science are deeply intertwined. As I like to think, understanding the key philosophical assumptions that we make in science can lead to better science. Her work is inspiring, well-informed, critically important in our pursuit for better medicine and public health policies. I'm deeply honored to be able to introduce one of my intellectual idols, Dr. Anya Plutynski. And at this point, if we were face-to-face, it'd be a roar of the crowd, we'd be doing the wave, but unfortunately, they're all muted. So what we're going to do today is something slightly different from our standard. We are going to do something a little bit more informal, a little bit more active. So rather than having our visitor do a formal presentation, we will just have a conversation where we'll discuss her view in this paper. And anything that comes to mind, I get to play Oprah. And my thought is that we can do this for about 40 minutes and then followed by 20 minutes Q&A. If you have a question, raise your hand using the chat function. And Ken has kindly agreed to keep track of the order. So as always, students get first dibs when it comes to asking questions. So with that said, let's start. So in philosophy of medicine, even among those who work in specialized area, we don't usually find people working in specific disease area. What brought you to philosophy of cancer?
Well, I want to say thank you first for inviting me here. I'm really pleased and thrilled to be here and for that fantastic introduction. So I got interested in philosophy of cancer because I was diagnosed with breast cancer in 2009. I was nursing my daughter. She was still a little baby, and I found a lump and took it to my midwife and went to a surgeon, and I was thankfully diagnosed relatively early. So I went through the whole shebang. But I was puzzled because I was in my mid-30s. I had no family history of breast cancer. I was tested for BRCA1 and 2, so I didn't have any of those risk factors that might have indicated I would be likely to get breast cancer so young. So I just started learning as much as I could about it. And I realized that a lot of the things that I had been thinking about in the context of philosophy of biology, about explanation and reductionism and appeals to genes and explanations and things like that, were very closely relevant to questions in cancer research. But I just had lots of questions about all these gray areas in medicine that I didn't know about. I sort of assumed when I went to a physician to get treated that they would just tell me what to do. And it turns out that there were all sorts of decisions along the way, and I just started reading as much as I could about, well, how do I make the right decision? This is complicated. There's all these risks and benefits of both sides. And I realized there's this whole area of inquiry that really deserves more philosophical attention. And that became my new research project.
Wow. A friend of mine once said to me that all research is personal, and I'm becoming more and more convinced of that. One of the overarching theme of your paper, and really quite a bit of your work, is the role values play in scientific practice. For those who are not familiar with values, how would you describe that? Why are values critical, and what role do they play in scientific practice?
Well, we all have values that guide, of course, our everyday decision-making process, from, whether to drive or walk to work, to major life decisions like what career to pursue. And sometimes it can take a big decision-making process to make us think carefully about what we value and how we value one thing or another. And I think that one of the things that occurred to me when I started going into the physicians and making decisions about my cancer care was that things that I thought would be no-brainers and straightforward, like I said, I thought, the doctor would just tell me what to do because this is what the evidence said. I realized that there were risks and benefits of either choice. And so when physicians talk about effective care, right, and what we mean by effectiveness, it's not simply an empirical question, but we're also talking about weighing risks and benefits of various kinds of outcomes. And those are going to be evaluative judgments to some extent. So where we think which risk is more serious or less serious is going to determine how we assess the evidence and communicate it to patients. So I guess the sort of obvious case for today's conversation is screening. I think people tend to think of cancer screening as a no-brainer, better safe than sorry, right? But I think one of the things that I wanted to argue in this paper is that there are risks on both sides, both to getting screened as well as to not getting screened, and that values are going to help us decide which risks we might think are more or less serious. And I also think, of course, in the sort of general sense, when we're doing scientific inquiry, the most basic way in which values might play a role is risk of error, right? So when we decide to set a p-value at here versus there, right, we're making decisions about what kind of error we're willing to risk. And so depending upon the outcomes of our research, we might be making value-laden choices there, right? And so,
Right.
I know, yeah, people have been arguing a lot about medical reversals, and in this context, I think a big concern some people have raised is whether we should be changing our standards and thinking about what kinds of evidence, sort of where we want to set the bar for various kinds of error.
Right. That sounds a lot like almost a summary of the argument from inductive risk. Is that right? Am I getting that right?
So this concept of inductive risk, and I should say Richard Redner came up with it, at least at first here at WashU. He was a philosopher, and he wrote this paper like several decades ago suggesting that anytime the scientist, qua scientist, makes value-laden decisions, he's going to, anytime the scientist decides they're going to risk the error this direction or that direction, that's a value-laden choice, right? So even design of experiments, two-tailed versus one-tailed tests, right? There are going to be chances of error on various directions that have consequences. And so thinking through those consequences seems pretty important.
So it seems like it's not driven by evidence and logic per se or algorithm, but driven by something else entirely in terms of how we perceive, given that there's a value choice to be made.
So yes. Maybe I don't understand the question. That sounded like a statement to me.
Yeah, it is a statement. Yeah. Good. Yeah. At least I'm not losing my mind, which is something to hang on to these days. You mentioned in the paper, and I like this. You point out that there are three places where values come into play, and the first one is the endpoint, the choice of endpoint. And I love that Rudy Giuliani example because it really shows that the choice of endpoint can significantly affect the wisdom of screening. Can you say a little bit about that example, the Giuliani example?
Yeah, so I mean, this is a classic example. If you take epidemiology, you probably heard of lead time bias. So if you get screened early, right, you might find out about your cancer sooner. And so if you measure the value of screening in terms of 5-year survival rates, you could be aware of your cancer longer and yet not improve on your survival outcomes. So the example that I love is from Siddhartha Mukherjee's fantastic book, The Emperor of All Maladies. So he has two women, Hope and Prudence, who are deciding whether to get screened for cancer. And Hope decides to delay until, I believe, 55 or 60. And Prudence, they're identical twins, let's say, gets 5 years earlier, and she finds a cancer and is treated for it. If we're measuring the effectiveness of screening by the lights of 5-year survival, then knowing that you have cancer longer, right, might seem to be a good thing. But if both of them die at the exact same age, that's not necessarily an instance of a benefit. So the idea of endpoints is we want to look at what we care about. What are we really interested in finding out about? And in the context of, I know, precision oncology, one of the big issues that people have raised is that sometimes we're looking at things like progression-free survival or time to tumor recurrence instead of overall survival. And so there's some concern about whether one surrogate measure is really a good proxy for the endpoint that we are most interested in, which is often overall survival. Because living longer with maybe, quite a good deal of side effects and pain and suffering may or may not be a good thing. So,
right. So that choice actually dictates how the experiment is set up, how the screening, essentially the evaluation of the efficacy of screening,
and the communication of the results. Absolutely.
Right. It is kind of odd to think that it's not just as a global matter. It should be, mortality. It should be, are you going to live longer given a average patient? But rather, these other markers have a tendency to skew the data one way or the other. Another place that you point out the role of values is that in determining the efficacy of these public health measures, we often appeal to meta-analyses and systematic reviews. And there, you also think that the weighing of these different studies, pulling together data, can require injection of values. How is that?
So are you thinking of sort of systematic reviews that take? Yeah. So, I mean, when you do a meta-analysis, sometimes you have to decide to exclude some studies or include some other studies. And often those decisions are made on the basis of sort of grading of the quality of the research. And so, for instance, you might have good reason to think that there's a problem with a control in this study, or that the adequacy of the follow-up in another study isn't very good. And so those decisions do involve, to some extent, value-laden choices, right? We might want to prioritize this kind of quality of evidence over that, or prioritize this kind of study over that. And so the ultimate conclusion of these analyses isn't, as it were, purely empirical.
Right.
I mean, we want to make it as empirically informed as possible, but oftentimes there are choices you make along the way about what to include, what to exclude, and also how to simply present the evidence. And I think one of the reasons, for instance, the USPSTF's report in 2009 about breast cancer screening was received so negatively, why people were so up in arms about it was accompanied by a cost-benefit analysis. And so the report of the science and then the report of the cost-benefit was, I think, complicated things quite a bit, because people were troubled by the fact that they were attaching these measures to things like loss of life versus the psychological harm of having a false positive. And so these things got a lot of press, in part, I think, because of that particular report and the way it was framed and communicated.
Right. Do you have a concrete examples of what happened when we are pulling data together, where the kind of normalization of data requires us to to essentially weigh the risk of getting it wrong versus having a smaller pool?
Not off the top of my head, but it'll come to me if I have a moment.
Yeah, I was thinking about you had this example of using data from a long time ago when mammography was far less accurate than it is now. On paper, you just get the blunt numbers and you don't get the subtle consideration that the technology has changed so much in the last 30 years.
Yeah, and this was a big concern when I went to the Utah State Health Department when they were debating the results of the USPSTF report. One of the things that radiologists raised a concern about was that many of the original mammography trials were conducted, decades before many of the advances in the technology came around. So the concern was, well, can we really trust the results of this analysis given how far we've come? And I think that's a legitimate concern. And I think that one of the things that actually a lot of I think it was the American College of Radiologists have raised a concern about is that most of the people who were producing these reports, the USPSTF reports, were not themselves practicing clinicians. They weren't radiologists. And so the thought is that there's maybe some more sort of applied knowledge that they're lacking. If they're just looking at the sort of the studies and summarizing the studies and looking at the statistics and the epidemiological data, that maybe they're missing something important about the practice, the clinical practice. And I think that there's something to that, though there are trade-offs here. Like if you look at, they used to have these things called consensus conferences, where they would have an authoritative body come to the NIH and give a report on like what kinds of treatments are effective for which kinds of conditions. And some of the parties to these consensus conferences had a vested interest in certain kinds of conditions being treated certain kinds of ways.
Right.
There's some famous examples of this. And so there's a concern about whether a consensus produced by people who are, participants in the producers of a particular kind of drug, or, have a vested interest in this could have a certain bias or slant things in a particular direction. And so I think things like the Cochrane database and the USPSTF are supposed to be relatively neutral. But of course, there's a lot of concern about whether you can be completely neutral and how to draw on all that different information, both clinical and sort of background data, yeah.
Right, and that brings up the idea that the third place that you mentioned that where values can come into play, which is where overdiagnoses occur in cancer. And overdiagnoses are different from false positives. With false positives, you don't actually have cancer, but you were incorrectly diagnosed. And that's a well demonstrated phenomenon using Bayes' theorem. Overdiagnosis is rather that you do have cancer, but the cancer is such that it's slow moving or that it won't lead to clinical consequences. So it is overdiagnosis that I think where you really make a compelling argument that values come into play here. Can you say a bit about that?
So there's been a lot of debate about the extent of overdiagnosis, and I would say that in the studies that have been produced, I was sort of shocked at the range of numbers I saw for how often, say, prostate cancer, breast cancer, thyroid cancer are overdiagnosed, and how the range of numbers varied across different journals. Right. So like in some journals that you would find like the range is as high as like 20 to 40%. And then in others it was like 10%. And I thought, well, why did they have such different numbers for the rate, the rate of overdiagnosis of these cancers? So overdiagnosis is when you're diagnosing a cancer. And we know pretty well, I think, in prostate cancer that there are some slow growing cancers, right? Where men die with prostate cancer, but not of prostate cancer. And if you look at the spike in incidence and then the sort of fall off in mortality for prostate cancer right around the mid 90s, and then it sort of fell off, it looks like it wasn't proportional, and that maybe we were overdiagnosing a lot of these slow growing or indolent prostate cancers as cancer that may never have progressed in the lifetime of the patient. But then the estimates of those numbers, like how often that actually occurs, ranged really widely. And I take it that there's lots of reasons for that. Part of it is, this is a moving target. As we learn more, as we gather more data, we're going to better understand what the range of values is. Part of it is that the evidence is always going to be indirect. So whether you're looking at sort of autopsy data, right? So autopsy data can be used to estimate overdiagnosis if we know there's a reservoir of undetected cancers in otherwise healthy individuals who die from other causes. That suggests that maybe if we were screening regularly, starting perhaps at earlier ages or more frequently, we might find more cancers. That can be used as an estimate. Follow-up on mammography trials is used as an estimate for overdiagnosis. So looking at the catch-up cancers in the control group could help you estimate it. And there's a variety of different sources of evidence you can use to estimate it, but it's always going to be indirect. And so how you estimate that is shaped, I think, in part by how you're weighting different kinds of evidence and,
right.
you know, whether you regard this evidence as more or less decisive. And this is I think it's going to be, it's a hard thing to estimate overdiagnosis.
Do you think in some way oncology, I think oncology, especially some of the more well-known forms of cancer, becomes harder because the population that you are trying to draw data from, it's not, you know, quote, naive population. It's already been screened. It's already been, you know, the intervention is early on. We've always been told that the sooner you catch it, the better off you are. So to get the baseline number would be tremendously difficult.
Yeah, so a lot of these estimates depend ultimately on knowing what the baseline rate or the baseline prevalence will be. But of course, you know, we can't know that after the standard of care has been established where everyone's getting screened at a certain age. So sometimes you have to sort of extrapolate back and do your best to estimate what that might be.
Right.
And a lot of the sort of pushback, I think, from communities who want to sort of give us a lower number have suggested that maybe there's been a steadily increasing baseline number of cancers that might explain the fact that we don't see the fall off proportional in mortality that we would expect given how many more people we're screening and finding.
Yeah, you know, I was really fascinated by your discussion on overdiagnoses, partly because I think if I were, what would I do in that situation if I was diagnosed with cancer and my clinicians say, hey, listen, don't worry about this. You know, we can just do a kind of cautious waiting. I think the bias to intervene is so ingrained in the way that we practice medicine. I mean, who among us could sit on a positive cancer diagnosis and not do a whole lot? Do you feel like you're running up against that, you know, kind of psychological bias that we should do something, get this thing out of me right now?
Yeah, I mean, I think that when you hear cancer, I think that our tendency is to think that this is, you know, a severe condition and you better do everything you can to prevent it from invading and metastasizing. I think it's a big culture shift to think of some cancers as relatively indolent and slow growing. And for the most part, I think that despite these reports that we're getting of overdiagnosis and overtreatment, many, if not most, clinicians still will just treat regardless. Right. And recommend treatment. And the thought is, well, better safe than sorry, right? Even if this is an indolent cancer, maybe it's better to go ahead and do something about it. Though I do happen to know a very courageous older man who's living with a very slow growing indolent prostate cancer, and he's doing just fine. He's playing tennis, he's doing great. And so I think that there are a few people, sort of brave folks who are really, yeah. But as I understand, one of the big pushes behind precision oncology is that we're going to be able to find biomarkers that tell us which kinds of cancer are more or less aggressive. And some of these are already in FDA trials, I believe, one for prostate cancer to identify markers that tell you, okay, these folks really should be treated aggressively, and perhaps these ones we can wait and see if they have a biomarker associated with this particular aggressive form. Yeah.
Right, and you know, at least until the biomarker technique is available, there's no way I could tell that my form of cancer is indolent until I have identified that I have cancer. So in some respect, it's a catch-22. If I have a public policy that says, let's slow the screening, then you also are not catching the people who could benefit from the screening too.
Yeah, yeah. So these this is one of the reasons I think why the USPSTF report was so controversial, is because people say, how could you possibly weigh the loss of life against, you know, these overdiagnosed and overtreated cases, or maybe just a higher rate of false positives. But anytime you institute a policy of screening, you are making such a choice. And so I think confronting it directly and communicating about it, both with patients and physicians, is better than sort of sweeping it under the carpet, because these are big decisions we're making. That it's a huge investment in time and resources and finances. So the more you screen, the more it's going to cost. You're going to have, especially high rates of false positives, return screening, follow-up screening, and potentially also multiple biopsies for people
Right.
who are, where they're finding something that looks like an early stage disease.
Yeah, the message of transparency, I think, came across clearly in your paper. I've been working on placebo effects and placebos in general, and one of the better established phenomenon in placebo study is that when patients are confident in the competency and certainty of their clinicians, the therapeutic benefits of whether it be placebo or verum treatments go up.
Mm-hmm.
So there might be actually a quasi-ethical question to ask, which is transparency actually a good thing if it actually robs us of some of the therapeutic benefit
That's
of
a great
medicine?
question. Yeah, that is a fantastic question. And I've seen arguments on both sides. So one of my former grad school colleagues, Peter Schwartz, has this paper with one of his colleagues in Indiana where he actually argues for less transparency. So opacity is better because it'll nudge patients in the right direction, which in his view is screen more. And I think that, I can see an argument for that in potentially some context where sort of patients are uncomfortable with making these decisions in a sort of shared decision-making framework. And a lot of patients are already resistant to screening and intervention. And so the idea is maybe this will nudge them more in that direction. On the other hand, maybe it's obvious in the paper. I'm a sort of big fan of autonomy and patient choice. And I also am a sort of fan of slow and gentle medicine. I think sometimes we are rather aggressive, especially in the United States. We order a lot of tests and treatments that are not all that effective. And if all that we can say about them is that they improve placebo effect, I'm not entirely sure I'm happy with that. It makes for pretty expensive medicine. Yeah. So, I think there's trade-offs at the individual level in terms of individual patient communication, but there's also trade-offs at the population level when we start thinking about the overall cost of care.
I was at a conference once across the street at the Harvard Medical School, and the presenter mentioned that orthopedic surgeries are oftentimes not particularly effective compared to sham surgery. In fact, 50% of sham surgery outperform the real thing. So one of the surgeons asked, "Are you telling me that those surgeries are placebo?" And the speaker said, "Yes, really expensive placebo, but they are placebo."
Well, and
I always like that point. But it is better than nothing. So part of the illusion, it's there.
You have to wonder, if that's the case, well, we're getting into some tricky areas here, but maybe insurance fraud isn't such a bad thing. Like you can imagine surgeons saying, "Oh yeah, I'll conduct that surgery, knock out the patient, make a few trims and come back." Yeah.
Yeah, there was
very expensive.
I have to talk about this because it's part of my shtick, but there was a case in Australia where this pharmaceutical company was busted for selling over-the-counter pain medication that had the exact same ingredients, but one was labeled for headache, one was labeled for back pain, one was labeled for fever, and it was all exactly the same pill. There were different boxes and different price points. And when the public got hold of this, it was obvious outrage, and the parliament passed a law that made it illegal for a farmer to do this. What they didn't anticipate was that when you package them differently and you have different price points, they do perform differently.
Wow.
So by being honest, you actually rob some of your drugs of the therapeutic benefit.
Yeah. No, I guess there's a case to be made that, and people have said this about a lot of antidepressants as well, is that even if for many patients it is a placebo effect, it's an awfully valuable placebo effect that we should continue to offer patients. Though I mean, I think that there's again, you have to think about side effects and trade-offs, because, you know, some of these patients may be experiencing quite serious side effects that, yeah, that they wouldn't otherwise accept if,
Yeah, you know, with the ubiquitous nature of values in medicine, I think your paper illustrates that well. Do you think values are essentially inevitable in medicine, that, you know, it's not, you know, there's this idea of value-free medicine. We should, and this has been a movement going on for 30, 40 years now, that as a clinicians, don't impose your personal values on your patient. But if values are necessarily there, how are we supposed to move forward?
Oh gosh, that's a hard question. That's a great question. We can spend the rest of this time talking about it. I think it's hard to avoid engaging in value-laden decision-making in medicine. And I think, in my view at least, what's important is that there's some transparency and communication about it, and some self-awareness on the part of physicians, because I think that physicians do bring commitments or values to various, even the commitment to evidence-based medicine, right? To prioritizing certain kinds of research over others is a certain value-laden judgment. And so I think there's more discussion of this among physicians. It should be part of medical education to think about these contexts where there are trade-offs and gray areas in medicine, and communicate more effectively about that with patients, though that's in itself a really tough thing to do well. And I think that I love the ideal of shared decision making, but I know that in practice, physicians are overwhelmed. They have limited time with patients. They have limited training in communication about risk, and that in itself is a barrier, and makes a lot of these ideals hard to put into practice. And I do acknowledge that sometimes philosophers bring very highfalutin ideals to a very complicated practical context of medicine. And
you don't say.
Yeah, so yeah.
Yeah, you know, I'm thinking of cases where values of a clinician, of a doctor, and the value of a patient conflict. You know, and one of my friends is a general surgeon, and she said that her mentor was really upset when the team performed a surgery that they thought was superfluous. The patient was already suffering from multiple organ failure, was completely unnecessary, but the family wanted it. And the mentor said, you have to remember, you are a gatekeeper. You're not a vending machine. You don't just do what they want you to do. You have to stand your ground. And that tells me that at least there's a culture of thinking that, no, some values are better than others, and sometimes your values are just off the chart. So I think some of those issues are going to creep up if we are more transparent.
Yeah. Absolutely.
You know?
Yeah, no, and I think this is why transparency and communication is so important. I mean, the place where this really comes out, I think, is in a lot of end-of-life decision-making. And I think because physicians are sometimes uncomfortable with talking to patients about the state of their cancer, the state of advancement of their cancer, that this drug is just not working anymore, that they end up doing more than they need to do and causing more suffering rather than less. And I think these are hard conversations to have. And I think that's part of it, is these are really difficult things to communicate about effectively.
So more practically, when I know what I do with my primary care, she and I have become good friends over the years because she knows how insane I am as a philosopher getting clinical care. When you meet a doctor, how do you communicate some of these more subtle and nuanced questions about what is the right treatment, what is the wrong treatment?
Oh gosh. So I know often rather quickly if someone's not receptive to questions and willing to sit down and have a conversation about what I value and what's important to me. And so I just decide to go to a different doctor if it's pretty obvious that they're not going to do that. So yeah, I think that people who have, biostatisticians, philosophers, people who do this kind of work are, those poor doctors, man, they've got to be really patient people. And I should, my doctor is a very patient woman. So, yeah.
I trust that you haven't assigned any readings to your clinicians.
Oh, no. I did, yeah, no.
Good.
I often ask them way too many questions.
Yes, I understand that. I'm going to pause it right there to see if we want to open this up for general conversation and questions. I'd like to bring in students first, since this is first of all for them. So,
well good. Jen, we've got one student alerted me to questions and also alerted me to the fact that it's hard, perhaps impossible, to find the raise your hand button. So I would encourage people to send a chat to me. You can see my name should have a yellow box around it at the moment, and that'll go away. But you all know how that works. Send a chat to me, and I will put you in the lineup. Right now, Divine Favor Okebunor has a question, and I'm sure that our faculty. I know I have plenty to talk to. So what I would say is, students, please send me a chat as soon as you can. You don't want to hear me question. So your strategy should be to send me lots of notes with your questions, or that just let me know that you have a question. And the game should be, how long can you keep Dr. Richmond quiet? That's the game. But right now we just have one, but I'll look for more chats.
Divine Favor, want to go ahead?
Good evening. First of all, I want to tell Dr. Richmond, thank you for saying my name right.
Oh, good.
And I'm sorry, this might be a silly question, but at the beginning, when we were speaking of lead time bias and overdiagnosis, I remembered a part of your paper where it said reduction in age-adjusted cancer mortality should be used as an endpoint. And again, this might be a stupid question, but I did want to ask, why use that rather than quality of life since early diagnosis? Like the example you gave of the two sisters, the Hope and Prudence, it said one found out 5 years earlier, but they still died around the same time. If one of them, if her early diagnosis led to her having, because chemo makes you sick and stuff like that, and the other one would probably have had more time to be active, less time being sick. If one of them had a better quality of life, doesn't that show that lead time, sorry, I'm very sorry. If one of them had a better quality of life, doesn't that show that screening earlier doesn't really help? That was my question.
Yes, exactly. And that's what the case of Giuliani is meant to illustrate, that knowing earlier isn't necessarily better, right? So that we could have earlier knowledge of cancer doesn't necessarily improve overall mortality outcomes. But I take it like the first part of your question, and let me see if I've got this right. Divine Favor?
Divine Favor, yes.
Yes, oh, that's beautiful. What a lovely name. I think that thinking about quality of life as an endpoint as well is really, really important. And I know that some people have tried to accommodate this and measure these things, QALYs, DALYs, and so on. But I think it's a very difficult thing to quantify and measure at the population level and put into practice when we're testing for various outcomes. Whereas, yeah, so I think that in principle, that would be a really important thing to take into consideration. But with respect to screening, I think looking at mortality instead of 5-year survival is absolutely essential to avoid the problem of lead time bias. I don't know if I answered your question.
You actually did. Thank you very much, ma'am.
Okay.
If it's all right, if there's no other question, may I ask one more?
Absolutely.
At one point, we did speak of the placebo effect, and you said letting people know earlier that like early screening would not be that much of a help might put down therapeutic benefits. And I was thinking, there are some times when people know it's a placebo and it still works. So doesn't that negate the argument that you need to keep people in the dark for the therapeutic benefits?
Oh, okay. I'd love to know more about some examples of this, because I'd be really, I mean, maybe Diane can to jump in here, but that's really interesting. So they
they're called open label placebos, where you actually tell people that you're giving them placebos, and they still have some therapeutic benefit. There's a well-known IBS study in Spain where the control was regular, no flavor placebo, and the active was mint flavor placebo. And they were told they were placebos. And it was so effective for some of the subjects that some of them requested that they have a prescription for the placebo after the trial was over. It was incredible. And that's been somewhat of the cutting edge of placebo study, which is what happened. We disclose that information.
That's fascinating. Wow.
Yeah. The idea that medicine involves performative, that you go through the motion of self-care and that actually have benefits, is starting to emerge as a plausible picture.
Well, I mean, I think there's absolutely something, when you look at the history of medicine, a lot of, and in different cultures and times, a big part of medicine and healing is ritual. And we've lost that. And that's actually, it seems to me, very, very important, the rituals of medicine, the performative aspects of medicine. I saw a fantastic talk once at University of Utah by, oh gosh, I'm going to mispronounce his name. Is it Gwande? About touch and the importance of touch in healing, physicians' touch. And that seems like such a minor thing, but it can be very, very important to how patients experience the interaction with a physician.
Thank you very much.
Good. We've got a couple of other students who have let me know that there are questions.
If I may, just one last thing. I'm very sorry.
Oh, good. That's perfect.
Ma'am, I think the name you were trying to say was Atul Gawande.
Ah, thank you.
That's it. I'm out.
Super, thank you. So here's a name that I'm not as confident about. Anihureman Osumbor was next on my list, and after that, Abby Spangler, and then Jeannie Fan.
Yeah, hi. It's nice to meet you. Your paper is very interesting. So it was like very complex. I think philosophy is very complex, very complicated. I think, you know, not a lot of people would like ordinarily like think about a lot of the things that you talk about in your paper. So do you think that the average doctor or primary care physician today actually thinks about and is, or at least is aware of or like acknowledges like the uncertainty of medical practices? Because you concluded your paper by saying that that's basically the way, like doctors should like at least be aware, you know, at least acknowledge that a lot of the things you do are uncertain and have uncertain, you know, results. So do you think that the average doctor is like, you know, aware of all this?
That is a great question. Unfortunately, I'm not an empirical psychologist, but I can recommend a paper I assigned to my undergraduates in philosophy of medicine to you. Though it may not be as current, maybe Diane can recommend something more recent, but I have my students read a paper by this guy named Gerhard Gigerenzer and his colleagues, and it's called Helping Patients and Physicians Understand Health Statistics. I'll send a link to Diane. But it's he's done a lot of psychological studies on how physicians understand risk and communicate risk and think about uncertainty in medicine. And it looks like though physicians do a little bit better than ordinary folk in understanding and communicating about uncertainty and risk, a lot of them do have a sort of a blind spot when it comes to acknowledging and communicating effectively about uncertainty and risk. And I believe that Gigerenzer and his group of researchers have suggested various solutions and tools for helping physicians learn about and communicate more effectively about uncertainty. But I think it's a really hard thing to do when you're in a position of authority, and especially when you're advising a patient about decisions that could have huge impacts on their life and quality of life, to acknowledge that there's something you don't know. I mean, that's a pretty scary thing to acknowledge. Mm-hmm. So, I mean, I think there's a big psychological bias, I can imagine all of us would have in sort of telling someone from a position of authority, well, I don't know, but here's what I can tell you. So yeah, I mean, I think in principle, most physicians realize that there are gray areas in medicine, but I think in practice, acknowledging it and communicating about it is very difficult.
All right, thank you.
Mm-hmm.
Great. Abby Spangler is next.
Hi, nice to meet you. In addition to being in Professor Ho's Philosophy of Medicine class, I also take a class called the Economics and Finance of Healthcare. And like this conversation, especially about overdiagnosis, have like really stimulated like my thoughts on that class as well. So I was wondering if you could just like expand on like the financial incentives, like our health insurance policy in the United States, and how that relates to like overdiagnosis and like any other factors that come into play behind like overdiagnosis.
What a great question. Thank you so much. That's a fantastic question, Abby. I'm sure your professor in your health economics class could give many, many more examples than I could, but I know that one of the things the Affordable Care Act was trying to do was reduce ineffective and inefficient care by changing the way that things were sort of the structure of care. I think that sometimes promotes over-treatment and over-testing. And so making it more evidence-based, tracking the cost in terms of what is effective as opposed to, whether we're just doing one more procedure and so getting paid for one more procedure, I think is really ideal in principle. I think putting it in practice is hard because we have a very complicated, messy, multi-layered system. And as all of us know, the Affordable Care Act has faced a lot of resistance. And so, in principle, it would be cost-effective, efficient, and not motivated by profit, but sometimes that's not always the case. So you probably know more about this, Abby, than I do since you're taking the class. I would love to have a copy of the syllabus if you would be willing to share it. That sounds fascinating.
Thank you.
Mm-hmm.
Maybe I can send a copy to Professor Ho.
Yes, I'll take care of that. Yeah, and of course, I'm going to speak on behalf of Anya. I'm sure she'll be happy to hear from our students too. They're a good bunch.
I bet they know a ton about this. I have my students in philosophy of medicine. We always read this. Have you read Jeremy Green? So it's about the history of the development of 3 major drugs associated with heart disease. So drugs to treat high blood pressure, high cholesterol, and I think it's a fantastic, I mean, he's a fantastic historian, but it's a fantastic history of how these categories of high cholesterol and high blood pressure were shaped in part by the development of drugs to treat them. And so that these expanding populations of people who are being treated, and indeed the cost of these drugs and the profits associated with them is not a sort of direct matter of just the science coming out and then we decide to treat more people. It's a very complicated historical story, yeah. So.
Great. Jeannie Fan is next. If I would encourage anybody, students and non-students, to send me a note if you want to be next in the queue.
Hi, I'm Jeannie. Hi. So regarding like your paper and then the questions surrounding, I know like mainly focusing on cancer screening, but I'm also a research assistant for a mainly psychology / public health lab. And we do a lot of research regarding like autism, especially regarding like screening in children. And it's really like abundant in the literature, especially with regards to, you know, like early intervention, early screening, like in regards to more psychological disorders or different things of that nature. And so with regards to like, we're not necessarily looking at like mortality and things like that, but we're definitely looking at, you know, quality of life and with regards to especially like low income children or families, for example, like the need for early interventions to support learning and breaking the cycle of poverty is also something that we look at. But I guess I wanted to know your thoughts on that, especially with like values in a case where like autism research and there's so little evidence-based, like there's so little empirical things to look at that I feel like, especially culturally too, there's a lot of values and how treatments are placed and to what extent interventions are introduced. I just wanted to know your thoughts on kind of more the psychological realm or the less or other realms outside of cancer. Like, do your findings or do your findings in your paper sort of translate over to those areas as well? Have you thought more about those things, etc.?
Wow, that is a great question. Remind me of your name again. I'm sorry.
Jeannie.
Yeah, wow. I mean, I haven't thought about it, but you've given me a lot to think about, and it does seem important to take into consideration both in the psychological and the sort of clinical medicine end of things, costs and benefits, trade-offs involved. I can see how in the psychological case, early intervention for various learning challenges and providing tools for kids with those challenges would be really important. I think that the downsides, like in every intervention, right, there's going to be a downside. So I guess the risk might be overdiagnosis, though overtreatment is a bit different here because we're not necessarily talking about administration of drugs in children, though I guess there could be cases where we're giving Ritalin to kids who maybe don't need it. And I know that can have long-term consequences in terms of health. So I guess it would depend upon the particular test and the particular intervention that we're talking about, what risks and benefits are associated. But that is a fantastic question and well worth, yeah, some philosophical attention. If someone's listening, there should be there's a dissertation to write.
Hey, Ms. Van, you may be interested to know that our next talk, which is coming up in November, is about outcomes assessment and the goals of interventions for autism.
Awesome.
So
yeah,
that's
like
absolutely on topic for us.
Yeah, the word overdiagnosis doesn't come up, I feel like, a lot in the literature I've looked at, but definitely the issue of like misdiagnoses is a huge concern in, I feel like, the autism research community. And so I feel like definitely when I was reading your paper, the same questions applied to a lot of the screening tactics. So I was just interested in your thoughts. So thank you so much for answering that.
Yeah, I think that this actually raises a really interesting question about how you think of overdiagnosis in these cases. So I can see like false positives, that's clearly a problem. But if conditions like autism or various behavioral challenges are a spectrum, and they may or may not cause serious symptoms or necessarily require various interventions, I can see a case to be made for something like overdiagnosis in those cases. But I think it's a really interesting question about how we think about these conditions. And I know in mental health, there's a lot of debate about how we think of these as sharp versus graded. Yeah, so I think that's an interesting question to think about. Fantastic question.
Thank you.
Well, that gets us to the end of the queue. I don't know, Dr. Ho, how you want to, if you want to wrap up or if you want to open.
Yeah, so we got a few more minutes. I will allow the the bottom of the barrel, aka faculty members, to ask their questions as well. So please chime in.
And remember, I'm waiting. The game was keep Ken quiet by asking questions. So far, you've been doing well, but you're not going to win unless you speak up.
Janet, go ahead.
I like to hear Ken talk. So, but we'll see. Maybe I have a similar kind of question. So, yeah, and apologies because I've been barely keeping my head above water. So I haven't read the paper. So this may or may not have been addressed. But, you know, I know when I teach public health, we talk a lot about health disparities and a lot of the issues that we have with underdiagnosis in certain populations. So yeah, just kind of wondering, like, how do you kind of balance all of these different factors that we're talking about with, you know, just the tremendous health disparities we have in surveillance and diagnosis, especially of cancer in certain populations in the US?
Fantastic question. Yeah, I think that I sort of set that all to one side for the purposes of this paper, but I actually, I think it's really, really important. And I talk about it a lot in my bioethics classes and medical humanities is this question of access and also, I mean, I think there's also huge issues of testimonial justice. I've just been thinking about this a lot in one of my other classes because I think what happens often is these diagnoses are late because people come in with complaints that aren't taken seriously. And that's a huge problem. So I think there's so many contributing causes to inequitable access, inequitable distribution, inequitable testimonial. Yeah, but those are huge issues that I'm looking at it more from a perspective of, given the evidence we have, how are we doing in terms of effectiveness of diagnosis and treatment, right, within those populations that are being screened. Not always everyone, for sure.
Thank you. And just as a funny note, my daughter's a junior at WashU, so I told her about your talk today, and yeah, and you know, she's a double major in psychology and political science, but she wished, you know, she wanted to kind of stop by just because she was really intrigued by the talk. So I'll give her a summary.
Okay.
Yeah, she should add the philosophy major. WashU is an amazing philosophy department. So I'm just putting it out there.
Well, professor moms have to be careful about interfering too much with the autonomy of their 20-year-olds. So.
Let's take one last question. Ken, we might lose, so go ahead.
Great, I can unmute. I know how to do that. So I think, you know, Dan and I and you, Anya, probably have very, very similar views of the role of values in medicine and science. That is, there have to be values, otherwise it couldn't get anything done, and some values are better than others, right? I think in some of the way you're describing your work, and also in some of the chapter, it's you kind of veer towards suggesting that, well, there are values and that's kind of icky or something bad, but we have to deal with it, right? But deep down, I think your position is it's not something bad, right? It's just part of the game. It's just, you know, you couldn't do it at all. It's just part of what we're doing. But I wonder if you could dig down deep for us, down to the bottom level of the values, and tell us which are the good values, right? Because I didn't really hear you say that. I mean, is it, because, you know, I always say that when you dig down, you're going to get a dilemma, right? For instance, you're going to get sort of health, well-being, and more life, or, you know, pleasant existence and staying alive, right? And sometimes it's health, you know, et cetera. So this is the question I'd like to, and I have plenty more, but I'd like to know if you know, it doesn't sound like you're entirely gonna buy into truth as the most important thing, even though the paper is partly about avoiding error. So what are the rock bottom values? And if so, what are they? What are the things you really care about, or you think that we should care about?
Wow, what a fantastic question. How many minutes do we have left?
-3.
Oh dear. Okay. Well, I should confess that like when I first started grad school in philosophy, I went to Penn because I wanted to work on Kant. And I'm a huge, I mean, maybe it's kind of
Almost did that too, by the way.
I mean, maybe it's a little bit obvious that I'm a big fan, and I have a particular bias with respect to concern with autonomy and in this context, patient decision making and transparency. I really think that's important. Whether it is ultimately important in service of something like overall happiness, pleasure, well-being, yeah, we could have a very long conversation about that. Here's what I can say. I think that one of the things that was interesting to me about the context of screening is it does seem to be a case where questions about individual choice and questions about population level outcomes can sometimes come into tension. And so I thought this was a really interesting place for bioethicists and philosophers of medicine to look closely about how and why they could come into tension and how we weigh them differently. I think that when I teach this material, often students come to it with a sort of individual decision-making bias, right? They're thinking, well, what would I do, right? Well, and Deanne kind of asked this question. He said, well, but if I were screened with, and I found a cancer, I would want to get treated, right? But I think one of the challenges of thinking about these hard cases in epidemiology is looking at the whole population level and making recommendations for screening or not in populations, and thinking about things at the population level, because I think many of us find that quite difficult. Weighing these things against each other, are we comparing incommensurable goods? And actually, one of the first questions from Divine Favor, which was a lovely question, was how do we weigh like life and quality of life in these contexts? I think this is huge, enormously difficult question. In thinking about cancer screening, and maybe respecting autonomy is part of respecting quality of life. At least in my view, it should be taken into consideration. I don't know if that answers your question. It was a tough question, Ken.
Well, partly. Maybe we could talk a little bit more. I mean, my thought is that in this very Kantian way, that what gives things value in large part is our choice to value it, right? Mm. And so that connects sort of, well, what makes a life good, and what we should value and why we should value it, and connecting with autonomy and also, humanity as an end in itself. But that's a tangled web of Kantian stuff.
Yes, yeah. And once you start thinking about autonomy as embedded and socially conditioned and shaped by, it gets
a lot of hand.
Yeah, absolutely.
Well, I'm going to thank our speaker. That was absolutely terrific, exactly as I expected. I'm so grateful that you have a chance to come speak with my class and to the community in general. And hopefully we will have you on campus at some point, and meet us and be here and see how great this place is, and we can all learn from you. So it was terrific, and thank you again.